Today we will be talking about important gynecological topic, which is pelvic inflammatory disease and a sequelae of that, tubo-ovarian abscess. So definition of PID. It's a spectrum of inflammatory disorders involved in the upper genital tract, which we can identify as endometrium, tubes, and ovaries, and the pelvic peritoneum. So the inflammation includes endometritis, self-meningitis, tube-ovarian abscess, and pelvic peritonitis. Tube-ovarian mass or abscess is defined as inflammatory mass involving the tube and associated with the ovary, which is characterized by pus collection, and it complicates PID and causes the abscess formation. So, when we consider in the clinical perspective, if we diagnose pelvic inflammatory disease, we should consider always empirical antibiotics. So, any sexually active woman who presents with recent onset low abdominal pain, which associated with tenderness on bimanual vaginal examination with cervical motion tenderness or uterine tenderness, and the pregnancy has been excluded, and there is no other cause or etiology for the pain, which always could be suspected to be having a PID. And it's highest in women who are aged less than 25, who are not using barrier contraceptions and with history of new sexual partner. So when we consider the etiology-wise, it's 30 to 40%, it is polymicrobial. And sometimes we couldn't find a pathogen when we do the pus cultures. The commonest causative organism is Chlamydia trachomatis or Neisseria gonorrhoeae. And with that, Gardnerella and anaerobes such as Pervitella and Mycoplasma genitalium can be seen. The insertion of intrauterine contraceptive device is a risk factor for PID, but it does not cause PID. Soon after the insertion, it usually takes around 4 to 6 weeks for the initiation of the etiology. So when we consider the clinical features, patient will present with low abdominal pain, usually bilateral, and associated with purulent vaginal or cervical discharge. And while they are having sexual intercourse, there would be deep dyspareunia. And most of the time, it's also associated with abnormal uterine bleeding, such as postcoital bleeding or menstrual bleeding. And with that, they may have secondary dysmenorrhea. So when we do the examination, we'll be able to elicit low abdominal tenderness, cervical motion tenderness, and adnexial tenderness. And sometimes the tube-ovarian mass may be felt in the adnexia and fever. So when we consider the differential diagnosis for this presentation, we have to always exclude ectopic pregnancy because it's a life-threatening condition. And sometimes there can be non-gynecological cause such as acute appendicitis present with the same features. But usually the cervical motion tenderness is not seen in appendicitis, but it depends on the position of the appendix. Sometimes the pelvic appendix can cause cervical motion tenderness if it is associated with the uterus, around 25% of the time. And in PID, usually they don't get vomiting. Endometriosis can be a differential diagnosis, but it usually happens cyclical manner, and the patient will have cyclical symptoms such as deep dyspareunia, dyschezia, and other cyclical symptoms involving dysuria while the menstruation. There can be ovarian cyst accidents such as ovarian torsion, bleeding into the cyst or rupture of the cyst. But usually you can diagnose it using ultrasound scan. There are telltale features are there, and usually it's very sudden onset, not gradual onset such as the PID. UTI can be there, but urinary symptoms will be more frequent. And rarely there can be irritable bowel syndrome, which usually related to the GI symptom. We use Rome 4 criteria to diagnose irritable bowel syndrome. So the pain usually lasts for more than 6 months, and it is usually associated with bowel movements. So the diagnosis, there is no definitive diagnosis. That is a clinical and ultrasound guided diagnosis. And Clinical signs, there is a possibility because there are a lot of differential diagnosis, sensitivity and specificity are low around, it depends around 60 to 90%. And in such case, in other countries, although we don't do it, they test for gonorrhea, trachomatis, and in the lower genital tract. So, and also that, as we remember, some of the time that we couldn't find a pathological organism. So, absence of infection does not exclude PID. And also, there's an important test that we can do called gram-stained vaginal smear, and we can't see pus cells from the gram stain. It has a good negative predictive value, around 95%. And also, if there is no tuboovarian abscess, it's uncomplicated PID, the ultrasound features will be very less. So the management, so what they say is, we have to treat on clinical suspicion because the delay in the treatment can increase risk of ectopic pregnancy, infertility, and the pelvic pain for the patient in the latter part of the life. So we should have a low threshold for empirical antibiotic, broad spectrum antibiotic therapy when a patient presents with likely symptoms. So rest, analgesia, and if the patient is having mild to moderate symptoms, we can manage with oral antibiotics. And IV antibiotics are conserved for more severe diseases such as tuberous abscess, pelvic peritonitis, or if they is having high fever more than 38 Celsius. So when we advise them to admit, usually that we do when we can't exclude the surgical causes or if there's lack of response to the oral therapy, if the patient is having any sort of immunosuppression, if there's a tuberous abscess, or the patient is pregnant. And also at the same time, we usually advise them to avoid intercourse to reduce the reinfection. And there are some places there is a place for partner tracing also. So the outpatient regimes, usually there are few regimes, but the commonest regime that we usually use is IM's ceftriaxone 1 gram single dose, which is followed by oral doxycycline 100 milligram BD with metronidazole 400 milligram BD for 14 days. Usually this can be given in the outpatient setting, and the metronidazole will cover for the anaerobe. And what they don't recommend, replacing ceftriaxone, although it's IM single dose, with any other oral cephalosporin. So this IM ceftriaxone dose is important. So this is according to Sri Lankan guideline. There's a slight difference is there. But usually for the MCQ purposes, better to go with the RCOG guideline based recommendation with IM ceftriaxone and oral doxycycline combined with oral metronidazole. So if the patient is having severe symptoms or if we are suspecting a tuberous abscess, then this IV ceftriaxone IM dose can be converted to IV ceftriaxone 2 gram daily with IV doxycycline for until 24 hours until the patient is having clinical improvement, followed by oral doxycycline and oral metronidazole for 14 days. So if the patient is allergic to penicillin, so you can use clindamycin and gentamicin. But if we are using gentamicin, we should be able to monitor the renal function because it's sometimes can cause nephrotoxicity, and there are few alternative regimes are there. So this is a Sri Lankan recommendation. They have recommended co-amoxicillin compared to the ceftriaxone, but ceftriaxone, doxycycline, metronidazole regime would be easier to remember and they will be MCQ related. So if the patient is pregnant, then the management differs. Usually we have to admit them and we continue IV ceftriaxone, which is sensitive for Neisseria, and we can't give doxycycline while the patient is pregnant, so we convert to IV erythromycin for the chlamydia cover-up, and IV metronidazole can be continued for the anaerobe. And usually we can convert to oral therapy following the clinical response, and we have to continue for 14 days as usual. So most of the time, surgical management is not needed in uncomplicated PID. but we can do laparoscopic adhesiolysis, and if there's any collection, we can drain using the laparoscopy. And USS guided aspiration is less invasive but equally effective. And in case of perihepatitis, performing adhesiolysis, there is no benefit regarding the duration of the treatment and the complications. So when we consider the complications, perihepatitis or Fitzhugh-Curtis syndrome due to chlamydia trachomatis, but there is no need of additional treatment if you identify this in the laparoscopy. And there can be tubular abscess, we will be talking about it later. And if the patient is having a intrauterine contraceptive device while on diagnosed to be have PID, so in mild to moderate PID, we can keep the intrauterine device because we are worried about unintended pregnancies if the patient had unprotected sexual intercourse during the last 5 to 7 days. But if the patient is not improving after 48 hours with the oral antibiotic in mild to moderate PID, we have to remove it and send it for culture and ABST. And to removing the UCD, we have to ask from the patient whether she had unprotected intercourse while preceding 7 days, and emergency contraception may be needed while removing the IUC. And if the patient is diagnosed with PID with diagnosis of retroviral disease, in that case, the routine antibiotic regime can be given, but the complications can be more. So that's for the PID. So IV antibiotics when the patient is having severe condition or the patient is pregnant or not responding to oral antibiotics. In mild to moderate symptoms, we can cover with oral antibiotics. And we have to optimize the other risk factors such as diabetes and look for immunosuppression. And key recommendation is proper antibiotic treatment on the proper duration to minimize the complications such as tubular abscess, chronic PID, and infertility in the latter part of the life. So tubular abscess means a inflammatory mass involving the tube and the ovary, and there is pus. So usually around 15 to 30% of the PID patients can go to tubular abscess. And usually the problem is these women are mostly in the reproductive age group and most of them are nulliparent. So the subsequent infertility effect will be rather devastating. So usually what happens is when the tubes or the endometrium get infected, this purulent material will discharge through the tube to the peritoneal cavity and then will progress to forming a tubular abscess. So compared to PID, it has high morbidity and life-threatening, and it can be easily associated with sepsis, in which case the mortality goes up to 10%. And although we consider it as a sequelae of the PID, tubular abscess can be caused secondary to appendicitis, diverticulitis, or pyelonephritis because of the translocation of the microorganisms from the renal system to the tubo-ovarian area, or appendicitis. Sometimes the inflamed appendix can seed the inflammatory material to the tubo-ovarian abscess, can be possible. And very rarely it can be caused by direct hemorrhaginous spread from an infection which is in the blood. So when we consider the risk factors added to the risk factors in the PID, that if they are not using barrier contraception, if there is an intrauterine device, previous episodes, recurrence of PID, and early initiation of sexual intercourse, multiple sexual partners, diabetes, immunocompromise, have respected, but sometimes because of the other etiologies, the tubo-ovarian abscess are found rarely, sometimes even in not sexually active women. So the diagnosis is clinical findings and radiological findings of tubo-ovarian abscess. Similar symptoms will be seen to the PID, but the clinical features would be more significant, like WBC would be higher compared to the PID, usually more than 15,000, and very high CRP. And compared to PID, there would be fever and diarrhea because of the irritation of the bowel by the abscess. And it is a clinical and ultrasonic diagnosis. There's no need to do the perform laparoscopy for the diagnosis per se. So imaging is very important. So ultrasound imaging is the first line, and it has good sensitivity and specificity around 80s. So there can be several ultrasonic features that we need to be familiar with, because sometimes the exam can give some pictures and ask questions. So there will be a appearance of unilateral or a bilateral complex solid and cystic mass, which has the normal appearance of the abscess. And sometimes we may see the dilated tube for the pyosalpines. It's elongated, dilated, sausage-shaped hypoechoic region, and we will be able to see the classic presentation of cogwheel side, or the small protrusions of the tube inside that hypoechoic fluid, which is shown here, cogwheel appearance. It's very sensitive marker. It's kind of pathognomonic for the tuboovarian abscess. It's caused by the thickened endosalpingeal folds protruding towards the lumen of the fallopian tube. So sometimes we may see the tuboovarian complex, which is inflamed ovary, which has polycystic appearance, and it's adhered to the uterus, which is in the early part of the PI tuboovarian abscess formation. So the management depends on the clinical findings and ultrasound. So if the patient is having sepsis, we have to treat according to septic guidelines. And if there's acute abdomen, we may have to go for the surgical management immediately in the rupture of a tuboovarian abscess, which can cause sepsis. And usually, initial treatment with antibiotic therapy. And sometimes we may be able to avoid surgical intervention, but depends on the patient's clinical presentation. So the medical treatment usually effective up to 70%, but there's a chance that patient may get recurrence if we don't do a surgical management. So initially broad spectrum antibiotics cover the commonest organisms using clindamycin, metronidazole, and cefixime, which has high penetration and reduce the size of the abscess. When the clinical improvement is noted and pyrexia resolved, we can convert to oral antibiotics and continue for total 14 days. So when we consider for the medical management, there are some poor prognostic factors such as the abscess size more than 5 centimeters, or the patient is elderly more than 40 years, and initial WBC count is high, and if the patient is a smoker. So there are a few regimes we can use, like oral ofloxacin with metronidazole, and clindamycin with gentamicin if there is penicillin allergy. So when the medical management is continued, we have to monitor. So usually there is monitoring according to a early warning system like NEO-START in the postpartum period. Fluid balance, urine output should be measured, daily WBC CRP, and if there is a need of thromboprophylaxis because it causes high risk for thromboprophylaxis, we can give like compression stocking, so low molecular weight heparin if we are not planning for a surgical therapy very recently. And usually this patient should be seen twice daily by a senior clinician. And if the patient is not having proper response, there is MDT approach should be taken, and the patient most probably suited to be monitored in a HDU or ICU facility because the patient can go into sepsis anytime. So surgical treatment is indicated when there is no response to IV antibiotics. And if the abscess is more than 8 centimeters, and when the surgery is required, there is a dilemma whether we do the surgery early as possible or we give some time for the antibiotic to act. So when we delay the surgery, there is an argument that exposure to purulent material can cause PID and infertility in the latter part, right? And if we go do the surgery on these fragile tissues, it can aggravate the fibrosis and adhesion. So in the clinical practice, usually what we do is, for 24 hours, we give IV antibiotics. There's no improvement, we go for the surgical management. And if the patient is deteriorating, then we go for the surgical management. So the tuboovarian abscess surgery can be difficult because these are inflamed fragile tissue and there will be tissue necrosis. So they are very difficult to handle. Stitching, tying, dissecting is going to be difficult. And when these fragile tissue, they tend to collapse. So veins, arteries tend to collapse. So they can bleed. And sometimes the peritoneal edema makes the peritoneum very thick. And thick peritoneum makes it very difficult to identify vital structures. And sometimes these bowel adhesions can be there. So when we are going for the adhesiolysis, there's a chance that we are damaging the bowel and making the problem worse. So surgical intervention per se, we can have few options. We can do laparoscopy or laparotomy with the drainage of the abscess, or we can go for unilateral salpingo-oophorectomy, or we can do radical surgery like pelvic clearance. So the management decision making depends on the past surgical history of the patient, fertility wishes, and the size of the abscess. So if the patient is not having previous significant abdominal surgeries, the abscess is not that large, and there are no other coexisting inflammatory conditions, the laparoscopy has benefits such as early recovery, less need of pain relief, early going into normal life, and cosmetic outcome. But in abscess per se, midline laparoscopy may be the preferred approach because it will give good exposure and good clearance. So fertility preservation is a problem. If you are going for a radical surgery, in such case, the drainage of the abscess and thorough irrigation with a large drain will be beneficial, depends on the patient. If the family is completed, we can go for a salpingo-oophorectomy to reduce the recurrence and need for surgery will be reduced. So if we need to remove the adnexia, even the woman wishing to maintain fertility, so we can do a laparoscopy. First look, if the condition is severe, we have to get the consent and go for the preferred surgery. And the pelvic clearance also it is gives a good outcome which reduce recurrence and need for further surgery. It's surgically difficult, challenging. It can cause infertility and premature menopause because of the we are removing the ovaries. So you can see when we compare the surgical management, there are pros and cons for each management. So in most of the cases, in the current practices, we do the laparoscopic adhesiolysis, drainage of the abscess, and antibiotic cover. 90% of them will be successful. And only the 10% will need radical surgery like salpingo-oophorectomy or the pelvic adnexial clearance. In a postmenopausal woman, because that she has already completed the family, and there's a chance that there is underlying malignancy, we usually have a low threshold for surgical management and having pelvic clearance, PHBS, because the associated malignancy risk is around 47%, almost 50% in postmenopausal age group. So we go for the total surgery at the first group. So in the postoperative period, we have to continue the antibiotic according to the microbiology opinion. Paralytic ileus is a very common complication because of the irritation of the pus, or we had a prolonged drainage, or we handled the bowel while surgery. And while doing that, treating the patient, we have to treat the partner because there's a chance of reinfection if the partner was not treated properly. And sometimes they may be having psychological trauma because of the future fertility wishes if they undergone a complete clearance. And if the patient did not improve following the surgery, we may need further imaging like CT to see any subnephric abscesses or intrathoracic abscesses. Secondary causes after the surgery, maybe. And if the patient, although we manage conservatively with a laparoscopic drainage approach, if the patient is having chronic pain, persistent adnexial mass, or recurrence, we may have to go for the pelvic clearance. So what they recommend is we have to avoid the elective procedure until 6 weeks from the initial episode, treat it, sort the initial tubular abscess, then go for the elective procedure later after 6 weeks. So in sometimes we may need to go to ultrasound or CTI guided drainage. Success rates are good. The good thing is it's minimally invasive, well tolerated, no need for hospital stay, and the anesthesia risk is avoided. But you need expertise for that. This ultrasound guided drainage may need transvaginal approach and need special instrument and the expertise. And sometimes we can even put pigtail catheters inside the abscess and let it drain. So this is a summary. So the tubular abscess is confirmed. We admit, start IV antibiotics, and we see any features of sepsis. If there's no features of sepsis, we do the observation and seen by a senior clinician. Get the microbiology opinion. If there's clinical improvement, we convert to oral antibiotic and discharge. There's no clinical improvement, or if this patient having signs of sepsis, we manage as sepsis. And there's no improvement within 24 hours, we go for the surgical management, like ultrasound guided drainage, laparoscopic drainage, or pelvic clearance surgery. And when the patient gets tuberine abscess during pregnancy, it can cause miscarriage, preterm labor, chorioamnionitis, and fetal or maternal death even in sepsis. So optimal treatment would be IV antibiotics and the surgical approach for the clearance. Depends on the gestational age also. But the thing is that compared to PID, appendicular abscesses are more common, which needs a MRI to confirm. So when we consider special requirements like IUCD, so IUCD is there associated with the tuberine abscess. Decision depends on the risk of unwanted pregnancy and the clinical outcome. And we should know a little bit about actinomyces, which is associated with the IUCD PID infection. And when we consider long-term complications, tissue damage, scarring of the tissue, adhesions, and fistula can be formed. So chronic pelvic pain, 1/3 of women will develop chronic pelvic pain. So it depends on the how many episodes they get, PID episodes, to which latter part of the life they may get. So it increases with the recurrence. And they have not found out, compared to IV antibiotics and the surgical treatment, there is no difference between the incidence of chronic pelvic pain. Subfertility, chance because of the adhesions and the damage to the tube. Usually what they say is, if we treat following antibiotics alone, subfertility will be less because we are not handling the tissue. So laparoscopic drainage, the risk can be around 30 to 60%. So if we are worried about the fertility, that the recommendation is go with the laparoscopic drainage rather than going for the pelvic clearance. And if the patient is having persistent hydrosalpingo which are not working, if the patient is going for IVS, better do the salpingectomy, because this fluid in these hydrosalpinges are embryotoxic. So they will be dripping into the endometrium and preventing the implantation. So if the patient is going for IVF, we may do the elective salpingectomy procedure. And these are my references, this BASH guideline, and there was a TOG regarding the tuberine abscess, and the antibiotic guideline, which is by the Sri Lankan College of Microbiologists in 2016, which is under revision. We may get another one latter part of this year. Thank you.